Hi, I'm Robin, and I am working with Ariel
Hi.
to. Hi. We are going to be talking about our diagnostic algorithm for acute compartment syndrome and kind of how to use this flowchart in practice. So, to start off with, you kind of need to know some history from your patient, or at least the mechanism of injury. So, for an acute compartment syndrome, the mechanism of injury is going to be blunt force trauma to a long bone, or and then a long bone fracture. So in this case, the long bone we're talking about would be the tibia or the fibula in the lower leg. Um, and then the tibial fractures are going to be the most common. So you want to make sure that you're figuring out with your patients what that mechanism of injury is, whether if you saw it happen, if you were like there and witnessed it, or if you weren't, maybe you were, your back was turned and you didn't see the actual like blunt force trauma, like, the kick or a ball or whatever. You want to make sure that you get that information because that's really key to leading you down this path to being able to make an assessment that your patient has acute traumatic compartment syndrome. So, going off of the history and the MOI, your patient is also going to report certain symptoms to you, and these are really important too. They're going to say that the pain that they're having is extremely high, and you're going to think that that pain level that they're telling you that they have, it does not match up with the injury that you witnessed or that you were told about. So you want to make sure that you're getting like a patient is giving you a number for that pain scale, because that's going to be kind of the best way that you can gauge that their pain might be out of proportion with their injury. They're also going to tell you that their leg is very tender, to the touch, just really, really painful, that they feel like their muscles are really tight, like they're putting a lot of pressure on the skin almost, and they just feel like everything is just about to burst out of their leg, but it can't. And then as that kind of progresses, they're going to report some numbness, tingling, burning sensation, and then even some weakness. So, drop foot and things like that. So that once you get past kind of what they're telling you, you want to get into your physical exam. So observation wise, you're going to want to see if there's any inflammation, edema, swelling, skin lacerations or lesions, especially that kicked by a cleat. The compartment syndrome is going to be your biggest concern, but you also want to watch for those lacerations or those lesions because that is a potential pathway for bacteria and infection to get into the compartments, which are already going to be like very susceptible to infection. We want to make sure we're checking the temperature of the skin to see if it's hot, red, is it cold and clammy, is it pale, and kind of waxy looking. Those are all really important things to make note of. And then when you're doing your palpations, make sure you're palpating all of the compartments of the lower leg. So anterior, deep posterior, and superficial posterior, as well as lateral. Um, Even though the research kind of supports that the anterior is the most commonly affected compartment, we still want to make sure we're checking all four compartments in that lower leg. And then just kind of feeling for tissue tension, tenderness, check capillary refill. So, squeeze those nail beds, see if they're refilling at an appropriate rate. Also checking distal pulses, especially with a lower leg compartment syndrome. You want to be checking that posterior tibial pulse, dorsal pedal pulse, and trying to see if you can feel them, how strong they are, and things like that. Um, and then from kind of those top three things of the physical examination, there are certain things that are kind of going to maybe steer you towards a differential diagnosis. So if they're just reporting that they have pain that's only induced with exercise, and they can really like pinpoint that localized pain along the anterior shin, that may lead you to like a differential diagnosis for mediotibial stress syndrome. And then if they've got swelling in the leg, cramping, they describe the pain as like a deep aching pain. The skin is red, discolored, kind of purple, and their leg is very, very warm. That might kind of send you down that path for a deep vein thrombosis. And Ariel is going to go ahead and kind of cover the neurological and then those 5 cardinal signs of compartment syndrome during your physical examination.
Alrighty, so we're going to dive a little bit deeper into the neurological symptoms or the neurological physical exam. So you're going to check their dermatomes. Basically, you're just checking L3, L4, L5, S1, S2. Make sure they have sensation in those lower extremity. You're also going to check the 2-point discrimination.
So for that 2-point discrimination, this one is kind of a little bit different than what maybe some people have done. But with compartment syndrome, your patient is going to report that they feel like it's a single point touching their skin at a much farther distance than what it should be. Like those 2 points could be pretty far apart, or they're going to tell you that they can't really even feel it at all. So this is kind of important for knowing whether or not there's like the pressure in the compartment is compromising the nerves in that compartment. Ariel?
And then you're also going to check their myotomes. You're basically just checking if those L3, L4, L5, S1, S2, if those muscles function properly, because when I go down to the 5 Ps, which I'm about to do right now, you'll understand why you want to do this. So the 5 Ps of compartment syndrome are pain out of the proportion with injury. So like Robin stated earlier, they're going to say that their pain is like excruciating if they just got kicked in the shin, which is not normal. So maybe they're saying, oh my gosh, my pain is like super deep, where they can't really pinpoint where the pain's at. They're gonna have polaris skin, so they're gonna have super pale skin. They're gonna have paresthesia, which is numbness and tingling in the lower extremity, so that's where your dermatomes come in. You're gonna have pulselessness, so you're gonna have a lack of a pulse at the lower extremity due to the buildup of pressure in the lower extremity. And then paralysis. So like that said, myotomes are gonna be super helpful for the paralysis section. And then acute compartment syndrome, key physical exam findings are the 5 Ps, obviously. And then if a patient complains of increased intercompartmental pressure, evidenced by tightness and rigidity of calf. And then also if they complain of decreased local tissue perfusion, evidenced by poor capillary refill and tissue discoloration. So if, say you check their capillary refill on their big toe and it's super slow, or it's not coming back at all, you obviously want to refer them to the emergency room.
So those are the key physical exam findings that you would find with acute compartment syndrome. So like Ariel said, those 5 Ps of compartment syndrome, so the pain out of proportion with the injury, pallor, so the pale skin tone, paresthesia, pulselessness, and paralysis, along with that increase in intercompartmental pressure and the decreased local tissue perfusion, so poor capillary refill, the discoloration of the skin. Those are going to be those main things that are going to tell you that there's likely an acute traumatic compartment syndrome. So the mechanism of injury of blunt force trauma or fracture, along with those key findings up here in the red, they will kind of point you down that track for acute compartment syndrome. And acute traumatic compartment syndrome is an emergent condition. So immediate referral to an emergency department is key to make sure that your patient, your athlete, whoever, they're getting the care that they need in order to prevent damage to the tissues, the nerves, and the structures in those compartments. So a lot of times the treatment is an emergency fasciotomy performed within the first 12 to 24 hours. Obviously, that is something that we as athletic trainers wouldn't do. That's something that our patients, our athletes would receive at an emergency department at the hospital. But Our job is to get them to the hospital as quickly as we can. So that is why we would want to use this diagnostic algorithm. So the biggest things kind of pointing out here is just the flow of it. The red boxes, those are your those things that point you down the line for compartment syndrome. Red, and it's an emergency, so we'll make sure that we are aware of those key physical exam findings that are going to tell us that our patients have compartment syndrome. Thank you very much, and I hope that you guys are all able to use this diagnostic algorithm in the future. But I hope that you never have to. I hope you never have to see compartment syndrome. But if you do, I hope that this is helpful. Thank you.